Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. It's my pleasure to welcome you to today's webinar, where we'll be exploring the relationship between pandemic preparedness and response and our efforts to eliminate hepatitis B and hepatitis C as global health threats. Next slide, please. We encourage you to be an active participant in the webinar. Please submit your questions to the Q&A feature of Zoom at the bottom of your screen. This webinar is recorded and will be posted at globalhep.org, our website, along with the slide presentations. It'll be joining a library of our other webinars that have been developed over the years, including one, a previous one that explored this relationship at an earlier stage in our response to the COVID-19 pandemic. While you're at globalhep.org, I encourage you to sign up for our newsletter, where you can get information about our webinar series and other resources that are available at globalhep.org. Next slide. We at the Coalition have been very interested in this relationship between hepatitis elimination and COVID-19 pandemic for quite some time. Obviously, we are here to advance progress toward hepatitis elimination, but we also had to examine, what was our role in the response to the COVID-19 pandemic, and how was that response affecting the efforts to eliminate hepatitis B and hepatitis C. So this just gives you some examples of the work that we conducted over the years of the pandemic, including some surveys that you'll be hearing about in a little bit more detail as we proceed forward in the webinar. Next slide, please. Also in September of 2020, we brought together a webinar as a side event of the United Nations General Assembly to begin to explore this relationship fairly early in the response to the COVID-19 pandemic. And I believe that some of this interest, just say on a personal level, was from my experience in responding to the first years of the AIDS epidemic and recognizing the transformations that occurred in response to that pandemic in clinical medicine, in public health, and indeed in many aspects of society, and was really interested early on to begin to think about what transformations would come from this large response to this new pandemic, of COVID-19. And some of the participants on the call in our webinar today were participants in that first webinar as we began to explore these different aspects of this relationship. Next slide. So through that ongoing work that was represented by those publications and by that early webinar and a series of oral presentations over the years, we've maintained this interest in this relationship. We really wanted to formalize it in a white paper, and so we began that effort a little over a year ago to really put this into more of a structured form, so that it could be used as a resource for policy development, for raising research questions and the like that could help both pandemic preparedness and response activities, as well as our efforts of hepatitis elimination. Really going to be the focus of our webinar today is looking at different aspects of information and perspectives that are shared in this white paper. And that white paper was released on our website this past spring, and again, is available on globalhep.org. So I'll be providing a few more perspectives, and then you'll be looking at our agenda today. As you can see, we're going to be looking at this sort of bidirectional relationships of how the investments in COVID-19 and pandemic preparedness can be applied to hepatitis elimination, and conversely, how is the infrastructure for viral hepatitis elimination really part of strengthening health systems to prepare for the next emerging threat. Then we'll be getting some perspectives from some global health leaders that have experience in the response to COVID-19. Next slide. For those of you that may be less familiar with hepatitis, we're speaking of hepatitis B and hepatitis C, two blood-borne viruses that can remain as chronic infections in the body, leading to liver inflammation, liver scarring or cirrhosis, and the onset of liver cancer. These are deadly viruses over time, responsible for over 1 million deaths a year from end-stage liver disease and liver cancer. Now, because we have effective prevention, such as hepatitis B vaccines, reliable tests, and effective treatments for hepatitis B and cures for hepatitis C, WHO and the United Nations have set goals for the elimination of hepatitis B and hepatitis C, seeking to markedly reduce new infections and mortality through access to those prevention care and treatment services. Now, as is true for many aspects of healthcare, the delivery of these services were limited during the COVID-19 response, particularly in the early phases of that response, as medical staff, other medical resources were redirected to the response to COVID-19, and social distancing measures made it difficult to have direct contact with patients. At the same time, because of the large investments in capacity, such as diagnostic testing and the development of new methods for testing, just one example of how the innovations coming from COVID-19 could be applied to endemic threat like hepatitis. So there are opportunities from the pandemic response to build capacity for hepatitis elimination. So for the development of the white paper, we conducted literature reviews to look for case studies. We conducted global surveys on 2 occasions, one in 2020 and the other one around 2022, interviewing clinicians and program managers. And we'll be giving you some examples of data from those surveys here in a moment. And then we interviewed key informants. These are the contributing authors to the white paper. I want to thank them again for their contributions. And you'll be hearing from a number of those over the next hour or so. We also had other informants, such as Nafisa Shotan, who's from Africa CDC, and Carolyn Reynolds, the co-founder of the Pandemic Action Network. What we tried, some of the data from the white paper include note how the human resources in hepatitis programs were redirected to serve in response to the COVID-19 epidemics in their countries. You can see the proportions there in 2020 in a survey among gastroenterologists in Southeast Asia, and the proportion in a follow-up survey that we conducted in 2022. Sizable proportions of workers in hepatitis programs being redirected to COVID-19, because of their experience in managing viral diseases for the large part. Also, hepatitis programs testing capacity was redirected to respond to COVID-19. If you look at the bottom bar, you see in our global survey, a large proportion of care providers and program managers reported that hepatitis testing equipment was repurposed for COVID-19. And Georgia and Egypt provide examples of how 2 countries with well-developed hepatitis elimination programs use that infrastructure early on to be redirected to COVID-19, which accelerated their response to the epidemic in their countries. And you'll be hearing more about those two examples here in a moment. Also, potential benefits of pandemic advancement for hepatitis testing and care. This is from our survey conducted in 2020, when already clinicians were reporting that testing access was already beginning to improve in their country, and that training for the management of infectious diseases was also beginning to improve, along with other improvements, as you can see there in that bar graph on the left. Just illustrating how hepatitis program is really uniquely placed to take advantage of lessons from COVID-19. Same time, as many on this webinar are aware, that the growth in viral diagnostic capacity in response to COVID-19 was tremendous globally. There were examples of countries getting PCR capacity in large measure for the very first time, such as Ethiopia or Ghana, or a move from manual PCR testing to automated testing, which improved both the volume and quality of testing in a country such as Pakistan, and then a move to making the testing more readily available, such as in mobile vans or even home testing, which makes that more of a routine and accepted method of testing, which can now be applied to a large public health threat, such as hepatitis. Sort of extending that concept of distance-based care beyond home testing, telemedicine gained in acceptance, and particularly here in the United States with changes in reimbursement, for example. Telemedicine has become more accepted, and in areas where access to care is even more of a challenge because of geography or number of test sites, telemedicine provides new opportunities to make care available in a convenient way that can improve patient care. And then lastly, there's been the transformation of data systems. During COVID, we became accustomed almost to a daily update of the number of cases and number of deaths around the world, reflecting this improvement in data systems, with, as you can see there on the left, large proportions of countries reporting improvements in their disease surveillance systems. In many ways, surveillance is the sort of the nervous system of the public health system, and it needs to be there to detect emerging threats. But strong surveillance systems are also needed for responses to large endemic threats, such as hepatitis, as well. So this holds promise for these improvements can be sustained for improving hepatitis surveillance. If you go back one, I think one area that we're particularly concerned about is the loss of this testing capacity. I've heard from a number of different sources that countries are beginning to take this new testing capacity offline, mothballing it, if you will, because they cannot afford the maintenance fees. They don't have staff to staff it because of the loss of COVID money, and they can't afford the kits to pay for other testing. So this is an opportunity that needs to be sustained rather than lost. So looking ahead, we just our recommendations coming from the white paper. So we really need to look for opportunities to repurpose COVID-19 testing and vaccination infrastructure to strengthen the hepatitis response, and to recognize these transformations that have improved access to care, sustain those over time, and then apply them to a large endemic threat such as hepatitis. That has the benefit of sustaining support for that capacity, so it can be sustained, and also serves as a stress test for the system, so that if your system is working well in responding to an endemic threat like hepatitis, it's probably in good shape to respond to that next emerging threat down the road. And so therefore, incorporating hepatitis elimination into pandemic preparedness makes sense, because those vaccination, virologic testing, and surveillance services all can be applied to an epidemic threat. So we put together this infographic just to make that point of the interrelationship between detection, response, and prevention. So now let's look at some case studies of leveraging COVID investments for hepatitis elimination. And we're going to first hear from Dr. Nida Ali, who is a physician in Pakistan. She completed her fellowship in global health at Emory University. She assisted the Division of Viral Hepatitis at CDC in work on hepatitis B vaccine. And she spent time with us here in Atlanta at the headquarters of the coalition, and is now a coalition global hepatitis elimination fellow in her native country of Pakistan. And I'll turn it over to Nida. Nida?
Can you see my screen, the slideshow?
You go to slideshow.
Yes, but not in presentation mode.
Oh, okay.
Just go over the slideshow there at the top.
Yeah.
To the right. There. Up, go up. Slightly to the right.
Okay, let me share that once again. Yeah. Do you see the correct view now?
Yes, good. Go ahead, please.
All right. So thank you for the introduction, John. I'm working as a Hepatitis Elimination Research and Outreach Fellow in Pakistan, and currently leading this project, LEAP, Local Hepatitis Elimination and Prevention. Now, most of us already are aware that Pakistan is the highest burden country in the world in terms of the number of patients living with hepatitis C. And that means just because of hepatitis C related death, related cause, we have one death every 20 minutes, which means that every hour we have at least 3 people dying of hepatitis C. On June 3rd, 2023, there was this MOU that was signed between Coalition for Global Hepatitis Elimination and Ministry of Primary and Secondary Healthcare, Punjab. And through this, we initiated this LEAP project, which is basically an implementation research project through which we aim to eliminate hepatitis in a particular geographic area with a catchment population of 100,000. And the first phase of this implementation is already in progress. And in subsequent slides, I will be showing what work has been done so far. So these services that have been listed here are being provided at the doorstep, which includes screening, viral load testing, hepatitis C treatment, care and follow-up, and linkage to care for hepatitis B, provision of birth dose and adult vaccination, and follow-up testing for checking the sustained virologic response. These are some of the media coverages from signing of the MOU that day in June. And so far, starting from July 10th up till August 28th, these are the numbers that we have tested. It's about 20,000, and the prevalence on rapid test for hepatitis B has been less than 1%, and for C has been 1.6%. Now, these numbers may seem low, but let me reiterate the fact that we have been testing children of all age group. We have been testing all age groups, regardless of the age, from a child who is 1 day old up to the maximum age that we have in the field, which is in our data, a 95-year-old. So these numbers may seem diluted, but this is the first study of its kind where we have included all age groups. And for PCR prevalence of hepatitis B, again, it's less than 1%, and for hepatitis C is also less than 1%, but the numbers are still big. And our teams have also vaccinated more than 5,000 individuals, and these 5,000 people are all over the age of 18, because in our cohort, most of the under 18 people are vaccinated through EPI program in their childhood. This is the case study that actually tells us how we use the resource from a COVID pandemic that was about to be wasted and utilized it for hepatitis elimination in our LEAP project. So this district health authority had hired 32 COVID vaccinators that was on top of the already available EPI vaccination staff that was present there. So with the help of these workers, there were 4 million people who were vaccinated in Rawalpindi district. Rawalpindi is a district in Pakistan, a large metropolitan city that has population of about 6 million. So the drive was really fast in the initial days of the pandemic, and it led to, of course, vaccination of 4 million people in this one district. But now the COVID-19 is actually waning off the global health scenario, and we are, just like John mentioned, we are at the risk of losing all these capacities, all those trained HR and testing capacity. So what we wanted to do was to sustain this capacity and use that for hepatitis elimination. So we hired these 32 COVID vaccinators as frontline hepatitis elimination workers, and they have all the skills that we needed, including vaccination, rapid diagnostic testing, drawing the blood samples, which one of our workers is doing in the field with this child, and yeah, all the other surveillance related tasks. So now, because we have done the special training for them and trained them not just for vaccination, but also for other surveillance related services, I want to mention that these workers are skilled in door-to-door surveillance of any kind of infection that may include airborne, waterborne, vector-borne, or bloodborne. And they are skilled at contact tracing, again, rapid testing, blood sampling, vaccination, data recording, and social mobilization. So imagine we have this staff that was about to be jobless, and now they have this capacity that they can be used as frontline pandemic response staff in case of any pandemic that hits, regardless of the route of transmission. The other thing was the lab that was established in Rawalpindi during the days of COVID. Initially, this was the lab that was established in 2009 for hepatitis B and hepatitis C PCR. And then in 2019, before the first case of COVID arose in our country, the lab was repurposed and sort of upgraded to BSL-3 grade for testing of COVID-19 PCRs at that point. So from late 2019 up till now, there have been more than 600,000 COVID PCRs done in that particular lab. But again, because the COVID-19 was waning off, this capacity was being lost. And the first visit that I did in this lab, what we saw was that there were a lot of kits and reagents of COVID testing that were filled up to the top in the refrigerators, but they were expired. So there was this huge capacity, but that was not being used. Similarly, the machines, they were not being maintained, and the staff that was hired, they were there, but literally not doing any testing like for weeks. So what we did was converted this particular lab into back into hepatitis B and hepatitis C PCR lab. We just had to invest very minimal resources. For example, the machines were the same. We only had to spend very minimal resources for buying PCR testing kits and reagents. And since the LEAP project has started, we have done more 284 PCR tests in that lab. So what this means is that there was this capacity where we could leverage COVID-19 investments to accelerate the fight against hepatitis elimination. Well, this is a very small portion, a very small project, and a very small number of patients, but it's still working. And when I look at other districts in Pakistan, there have been similar things going on in other districts. They are laying off COVID staff, and they have these fancy COVID labs that are underutilized. So there is this huge window of opportunity where we can use the same pilot and actually utilize these resources for good. And now that we have this infrastructure of a lab and skilled person, the LEAP project is actually really ready to respond to any kind of pandemic that hits with all the resources that we have. Thank you. That was it. Open for questions.
Very good. Thank you. We appreciate that contribution. Again, please, if you have any questions for Nita, please put them in the Q&A section, and let's see what time we have for open discussion at the completion of all the speakers. I think we'll move over to Dr. Mohammed Abdul Aziz at this point. Mohammed is the head of the Division of Disease Control at the Africa CDC. He's worked in a variety of positions there at the Africa CDC, as well as a variety of positions in his native country of Nigeria. And he was a participant in the webinar that we convened at the UN-GA in September 2020, and has been very involved in the response to COVID-19. And I look forward to his remarks. Mohammed. Just go off mute, Mohammed, please.
Can you see my screen?
We can. Just go to slideshow, please.
Okay. Where is that magic?
Here we go. You're on. Very good. Thank you.
Thank you. Thank you so much, John. And good morning, good afternoon, good evening to all the participants, depending on where you are. That's one legacy we learned from the COVID-19 Yeah, it's really a great honor and pleasure to talk today in this webinar on the building resilient health system, sharing investment in hepatitis elimination and pandemic preparedness. Okay. Africa CDC, as Dr. John just introduced, is an autonomous health institution of the African Union, established to support health initiatives of our member states. For those who don't know much about Africa CDC, you can go to our website. Africa CDC is a specialized agency. It gets its mandate from the African Union, and we have 5 different regions of the continent where Africa CDC also have regional offices. So Africa CDC is currently developing its internal strategy for HIV, TB, viral hepatitis, malaria, and NTDs. And this roadmap is heavy on delivering the aspirations and goals and objectives of the Cairo Declaration on Viral Hepatitis on the continent. So the Africa CDC Continental Viral Hepatitis Program and Prevention and Control Program is one of the main programs that the Division of Disease Control and Prevention is pushing. It aspires to work collaboratively and catalytically with all stakeholders to eliminate viral hepatitis as a public health threat from the continent through the provision of continental coordination mechanisms, strengthening national public health institutions, and encouraging local manufacturing of consumables, leveraging on existing Africa CDC pool purchasing platform for consumables, and reducing the prices of drugs and consumables for viral hepatitis prevention. It also includes investment in public health workforce and leadership programs, and increased domestic financing and supporting our member states. Very key among all of these is the support for national public health institutions, which include the laboratory. One of the things we learned very clearly from the COVID-19 pandemic is how within 1 year we could make a diagnosis of COVID-19, and you could sit in your house and make a confident diagnosis of COVID-19. And these are the lessons that we hope viral hepatitis prevention and control programs can pick. And now that COVID-19 is winding down, one of the things we hope to do in Africa CDC is see how we can repurpose some of these facilities, some of this capacity that COVID-19 has built into prevention and control of endemic diseases like hepatitis. Of course, prior to COVID-19, there were some challenges within the infectious diseases prevention and control programs on the African continent. One of the main challenges with the laboratory systems, and COVID-19 demonstrated how, with the will and courage, you can be able to surmount some of these challenges and really get it right, even on the African continent. So the biggest lessons we learned that Africa CDC was able to really support our member states in really vamping up laboratory capacity, especially for COVID-19. We put all of this in what we call our new public health order. And the new public health order in Africa is a roadmap to sustainable health outcomes and health security for the continent. One of the main pillars is strengthening Africa CDC and national public health institutions. And let me use this as an example. During the pandemic, Africa CDC built the capacity and capabilities in member states to strengthen their laboratory system. There was a huge diagnostic capacity that was created in response to COVID-19. And this capacity can now be repurposed, like I said, for the other endemic and infectious diseases. Africa CDC has worked very closely with member states to strengthen their laboratory health systems. And we want to see how what we've done in this area can be used to support the endemic diseases like viral hepatitis. And as you can see at the beginning of the pandemic, the first map of Africa shows there was absolutely no diagnostic capacity in January. In February, when the COVID-19 hit the continent, only 2 countries had the capacity, Senegal and South Africa. But by August 2020, Africa CDC, working with partners, have supported every single member state to be able to make a confident PCR diagnosis of COVID-19. This is a feat that we are very proud of, but we are also looking at how, as NIDA have said, some of this capacity are excess now. How do we ensure that this capacity that we've developed are not just wasted and are used for endemic diseases, which, by the way, are the ones really killing a lot of Africans. So the RESNET program is one of those we are trying to use, which brings laboratory and surveillance networks together, and also try to see how we can build the capacity of some of these labs using the quality assurance and external quality assessment, the SLIMTA program, to support them on the African continent. In this regard, I think we've supported in the Central Africa, we've supported 7 labs who are enrolled on the ISO 1518 accreditation, and more than 200 laboratory workers were trained. The second pillar is investment in public health workforce and leadership programs to ensure Africa CDC has its workforce as when it is needed. Our member state has the workforce. In this regard, we have several leadership program and the workforce development program that we have done, and all the trainings we've done. We want to see how we can leverage on all of this capacity to support the viral hepatitis prevention and control program on the continent. We need to invest in South-to-South collaboration. Countries have a lot to learn from each other, and they face many challenges and hurdles. Exchange program and this type of platform are what we really need to be able to move this forward. We need also to invest in our community health workers. Africa CDC has work to strengthen community health workers on the continent, to recognize, institutionalize, and be remunerated. But we want to use those community health workers to be not just for pandemic response, but also to be able to support in the prevention and control of viral hepatitis program. For instance, we used the pandemic, during the pandemic, community health workers to scale up massively testing. And this is something I think we can also do. We've seen it used very effectively in Egypt for scaling up for testing their workforce, not necessarily community health worker, but in other African countries, we think this is something we can do. Local manufacturing is one area that we also hope we can use to expand, especially supply of laboratory consumables. How do we ensure that every person requiring testing for viral hepatitis can get it and couple it with treatment? And we believe local manufacturing is one area where we need to really be able to develop this. Now, all of what I've said, one of the biggest lessons we've learned during the COVID-19 pandemic, and we want to use it for the endemic diseases, is domestic financing and integrated programs. We cannot do much if we as Africans do not rise up and own our health programs, meaning we, with the new DG, we have pushing to have the increased domestic financing for countries to reach their their domestic financing target of 15% of their national budget, and put many of these into endemic diseases, not just pandemics and outbreak response. And of course, we talk about respectful action-oriented partnership, the great partnership that we have with you, John Ward, and other partners in the viral hepatitis elimination program with our member state, Egypt, where we can work together with common goals and common objective, devoid of duplication and inefficiency. I think we will be able to move forward. We have seen challenges of hepatitis testing in the past, challenges of algorithms. At this level, we should be moving closer and closer to point of care testing, utilization, lack of testing policy. 50% of gene expert capacity is on TB, HIV program. It's not utilized, and this is where the capacity is. Can we repurpose some of these gene expert machines to be used for mass campaigns for viral hepatitis? And lack of data to monitor testing volume and results. Of course, cost varies widely from $5 to $200, particularly for PCR testing. But we've seen what COVID-19 has done on the continent of Africa in terms of increasing the capacity for PCR testing and really bringing down the cost of testing. Some of these, we hope, we're already seeing how we can work with the lab division to repurpose this for the use for hepatitis elimination. I've mentioned some of these, so let me just move forward. So the key takeaway is that the COVID-19 pandemic provides the will and pathway to an unprecedented scaling up of laboratory services on the continent. Lessons were learned during the response, and we can use it to fast track what we are doing in the hepatitis elimination. And this is what we hope to push on the continent as the apex continental public health institution. Of course, we have to work, like I said, on logistics and supply chain and break up silos, ensure that there's integration, the TB programs, the HIV programs. Excess capacity can be used for viral hepatitis and other programs, including now that we have COVID excess capacity. How do we transform them instead of just taking them out of action? Thank you. I'm not sure. I think I took more than the time allocated, but back to you, John.
Thank you very much, Mohammed. Excellent overview, bringing up important opportunities to maintain these transformative improvements in laboratory capacity, as well as the opportunity to break down silos through integrated care. Two important points. Thank you. I wanted to turn now to Dr. Youngmi Ji to share her perspectives. Dr. Ji is a special representative for health diplomacy of the Korea Foundation. She's a visiting professor at the Graduate School of Public Administration at Seoul National University. Previously, she served as Director General of the Center for Infectious Disease Research at the Korea CDC. And I think very relevant to our conversation today, she was a member of the WHO International Health Regulation Emergency Committee on COVID-19 and of the WHO Scientific Advisory Group for the Blueprint on Research and Development Preparedness for epidemics. And we're very happy to have her today. Youngmi, thank you for coming on. I know it's late in the evening there, so I'll turn it over to you. Thank you.
Thank you, John. Good morning, good afternoon, and good evening, colleagues. I'm Youngmi Ji, the Commission of Korea Disease Control and Prevention Agency. I will just try to. So can you see my slide?
Yes. Go ahead.
Okay, so first of all, I want to thank Dr. John Ward and Coalition for Global Hepatitis Elimination for inviting me to this very important webinar. And to achieve WHO's goal of eliminating viral hepatitis by 2030, many member states introduced national hepatitis elimination program that provide necessary support for screening, diagnosis, and treatment. However, disruption caused by COVID-19 could have unintentionally forced countries to scale down the viral hepatitis elimination program and delay the implementation, and thereby hindering progress towards reaching the WHO's goal of viral hepatitis elimination. And so now is the time for all member states to make concerted efforts to achieve the goal of eliminating viral hepatitis by 2030, recognizing hepatitis as one of the most critical global public health challenges while preparing for future epidemics and pandemics. So Korea has established the National Pandemic Preparedness and Response Plan in May this year, under the vision of building a safe society free from infectious diseases with agile and collaborative crisis management and resilient emergency response. And I do believe this plan to prepare for future pandemics can somehow also benefit our efforts to control viral hepatitis. And now I'm quite happy to mention that Korea has also established its first national strategic plan for viral hepatitis B and C control in March this year to achieve the goal of eliminating viral hepatitis by 2030 in line with WHO's hepatitis elimination goal. The 5-year plan includes upscaling the whole cycle for viral hepatitis cases from prevention through diagnosis and treatment. And we have been committed to make various efforts to control hepatitis B during the last 3 decades. And we have implemented the National Immunization Program for all infants in 1995, and perinatal HPV prevention program to prevent mother-to-infant transmission has been put in place since 2002, enabling infants born to mothers infected with hepatitis B to receive hepatitis B vaccination and immunoglobulin. And they were also eligible for free HPV antigen and antibody testing. And as a result, in 2008, Korea became the first country in the Western Pacific region to be certified by WHO for achieving the regional goal of hepatitis B control. And thanks to these endeavors, the prevalence rate of hepatitis B has decreased to 2.7% in 2021, from around 7% back during 1980s. And notably, we observed a significant improvement in reducing the prevalence rate of hepatitis B among children aged 10 to 18, dropping from 4% in the 1980s to 0.0% in 2021. So building on this momentum, we will continue to promote perinatal HPV prevention program and expand the program's eligibility to include multicultural families and foreigners. Furthermore, to achieve the goal of eliminating viral hepatitis by 2030, we have incorporated diverse programs for hepatitis C control into the first national strategic plan for viral hepatitis control. With this plan, we will ensure early detection of hepatitis C cases and promote linking diagnosed cases with optimal care and treatment. While Korea provides a national health screening program for all citizens, the program currently does not cover testing for hepatitis C. Therefore, we now want to include test screening for hepatitis C for a certain period and establish a follow-up system to improve the linking to optimal treatment for individuals with confirmed viral hepatitis through this screening program. And we have also initiated a pilot program targeting the treatment of high-risk groups of hepatitis C, including IV drug users and inmates of correctional institutions. As the world is recovering from COVID-19, it's crucial that the national capabilities and resources directed towards COVID-19 response and strategically share the strengthen the efforts to eliminate viral hepatitis and to prepare for emerging infectious diseases while considering the unique context of each country. And these efforts are especially important in the WHO Western Pacific region with relatively high morbidity and mortality related to viral hepatitis B and C. The strengthening governance and collaboration at the national and global levels would be crucial in achieving viral hepatitis elimination goal, and Korea stands ready to collaborate with all member states and share our experience, lessons learned, and relevant policies. We will also closely work with WHO and other international organizations and agencies, particularly the Coalition for Global Hepatitis Elimination or Task Force for Global Health. I do hope all member states will join the forces in fostering the global cooperation and collaborative framework for pandemic preparedness and elimination of hepatitis. Thank you.
Thank you very much, Yomi. Excellent overview. And it's really exciting to see the progress in the Republic of Korea with the development of their new strategic plan and a really remarkable contributions that lay the foundation for further progress toward elimination of hepatitis B and hepatitis C in the country. Thank you so much for sharing that with us. And I look forward to working with you on building this global support for hepatitis elimination. Thank you again. And Lindsay, if you can return to our slides, I think we'll go to the second series of case studies. We'll begin to look at this to provide examples of how viral hepatitis elimination programs have did strengthen the a country's response to COVID-19. We'll first be hearing from Dr. Tamar Kabunya, who is a physician from Tbilisi State Medical University and holds an MPH from the University of Georgia here in the United States. She's currently the first Deputy Minister of Internally Displaced Persons from the Occupied Territories, Labor, Health, and Social Affairs Department of Georgia. She works as the first Deputy Minister, as I mentioned, in that regard. And I'll turn it over to Tamar. Welcome.
Thank you very much for your introduction. It's my privilege to share with you our experience of hepatitis C elimination, as well as describe how hepatitis C program helped us to be better prepared for the pandemic and overcome serious challenges we've experienced during, like many other countries experienced during COVID-19 pandemic. Georgia is a small country with 3.7 million population. Just to check, can you see my screen?
Yes.
Okay, thank you. Georgia is a small country with 3.7 million population. First ever hepatitis C seroprevalence survey in Georgia was conducted in 2015, and we found that approximately 7.7% of Georgian populations were anti-HCV positive, and 5.4% were HCV RNA positive, which indicated a quite substantial burden of hepatitis C in the country, and the decision was made to initiate hepatitis C elimination program, which was largely supported by the government and international partners, including Gilead Sciences, which provided access to life-saving drugs for free. And it's still like this. Georgia has very good support from Gilead, and drugs are readily available for all in need. So the first Georgian strategic plan for hepatitis elimination was developed in 2016, and it covered period 2016-2020. Key strategies were aimed at advocacy, awareness, education, partnership, and resource mobilization. We've implemented new programs for hepatitis C testing in healthcare setting and in general communities, which was very helpful to identify persons infected with viral hepatitis and offer them immediate treatment. In parallel with screening, we've developed laboratory capacity for confirmatory testing. Confirmatory tests were conducted initially in bigger central clinics. However, at this stage now you can get confirmation at many clinics at district level as well, and testing is readily available at primary care clinics as well as at Georgian Harm Reduction Network, which works with high-risk communities. It was very important to extend access to testing process, like screening possibilities to high-risk communities. These efforts resulted in a substantial decrease of hepatitis C prevalence by 2021. So repeated serosurvey showed that there was 67% decrease in seroprevalence, which was a great achievement. However, the program still continues its efforts to meet predefined targets. So these are key milestones. You can see that starting from 2015, a lot of efforts were made to improve testing capacity, make treatment available at more sites to make sure that we achieve our targets by 2025. And our targets are as presented on these slides. We are getting closer, but we still observe substantial gaps in relation to certain indicators. This is mainly related to treatment enrollment. These days, we have around 14,000 individuals confirmed with hepatitis C. They know that they need treatment, but for some reasons, they refuse to start on treatment. We've implemented targeted programs to tell them that they need specific treatment. However, it's not that easy to convince them to initiate on treatment. That's why these days we've been working on all directions of the care cascade. However, this is a key focus to make sure that we have all people confirmed with hepatitis C started on treatment. Georgia's success on hepatitis C elimination has been reported in various international journals and presented at various platforms. Key achievements which were very important related not only to hepatitis C elimination specifically, but also to strengthening public health capacity for detecting and timely treating of various conditions. It helped to improve infection prevention and control in medical and non-medical facilities. It also helped to introduce external quality assessment system, as I mentioned, with decentralized testing and treatment by building capacity of peripheral clinics, with integrated hepatitis C, HIV, and tuberculosis screening programs at primary care level and harm reduction sites. We've also introduced point-of-care viremia testing and treatment initiation, and this is now free of charge and widely available. All of these achievements, as I mentioned, was recognized, and Georgia was nominated as one of the best sites for hepatitis C elimination by US CDC, as well as Georgia was recognized and designated as World Health Organization Collaborating Center for the Elimination of Viral Hepatitis in 2022, meaning that Georgia is now open for partnership, and it's a regional partnership. We have visitors from regional like countries in the region which are interested in learning more about hepatitis C elimination, what worked, what didn't work so well, and then take this experience back to their settings. Of course, this is a huge experience, but we are very grateful for this designation and work hand in hand with World Health Organization and other partners to make the Georgian hepatitis C elimination model interesting and shareable to other countries as well. These days, as I mentioned, we are trying to continue our efforts to meet the program targets, as well as to expand the program to hepatitis B as well. So the new component was designed for the state program, which is aimed at hepatitis B elimination. This will include hepatitis B testing as well as treatment, and the drugs are not as expensive as it was for hepatitis C at the beginning, and we think that we can afford hepatitis B treatment drugs as well and provide a comprehensive coverage and to have hepatitis elimination program. So far, we were focused on hepatitis C, but now viral hepatitis would be our focus, including both hepatitis B and hepatitis C. Of course, having this experience helped a lot to address COVID-19 during a pandemic. Very important was having a well-established laboratory network, including PCR diagnostics. We had gene experts at district level clinics, and of course it helped us to quickly roll out COVID-19 PCR diagnostics and to have over 1 million Georgian citizens tested for COVID during the first year of pandemic. Of course, it was very important to have trained epidemiologists, which provided very good surveillance during COVID, contact tracing, and all that. Georgian National Center for Disease Control and Public Health acts as a reference laboratory, and this is very important to make sure that there is a good external quality assessment in the country, and this is how it works here in Georgia. And CDC acts as a referral laboratory for hepatitis testing, and it also did so for COVID-19, which helped a lot to make sure that we had a accurate testing system in place during pandemic. For treatment centers, of course, it was also helpful to have established treatment centers across the country. And those centers, they were actively involved in COVID-19 management as well. Primary healthcare doctors played a critical role, and of course, training provided during hepatitis C elimination program helped them a lot to then quickly get familiar with COVID-19 testing techniques and how to use it in people with COVID symptoms. Strengthening infection control and prevention system actually was a crucial outcome of hepatitis C elimination program, and like needless to explain how important it was for during COVID. In conclusion, I would like to say that allocating substantial resources to expand and strengthen healthcare system is very critical to be prepared for future pandemics. The process of building the hepatitis C elimination program in Georgia has promoted the progress of healthcare system across various directions, including infection prevention control, diagnostics care, PCR, disease prevention, health promotions. That's why it's very important to have a well-established public health infrastructure and trained human resources to make sure that the country is ready for future emerging threats, to address future emerging threats. International partnership was really crucial, and international partnership established during hepatitis C elimination program helped us a lot to access technical assistance very quickly in an efficient manner and have it implemented in the country for the sake of COVID control and COVID response. And I would like to take this opportunity and to express our sincere gratitude to all partners working with us during hepatitis C elimination program, as well as assisting us with COVID response and preparedness. We hope that this joint effort would enable us to achieve our targets by 2025, as well as to improve the system preparedness for future pandemic, and this contribute to strengthen the national health security agenda in the country and in the region. Thank you very much for this opportunity. Thanks.
Thank you very much, Tamar. Excellent overview. You gave us an update of the progress of the hepatitis C elimination program, which started before the COVID-19 pandemic, and then how it was applied to the COVID response in the country of Georgia. Thank you so much for that. Let's turn now to Dr. Wael Abdel Razik. He is the professor of hepatology and gastroenterology at the National Liver Institute in Manafia University, head of primary health care in the nursing sector at the Ministry of Health and Population. And he's the Deputy Executive Director of the National Committee for Control of Viral Hepatitis in the Ministry of Health and Population of Egypt. And I want to thank Wael for coming on and look forward to your remarks. Thank you.
Thank you, John, for the introduction. And thank you for the kind invitation. First, a glimpse about the magnitude of HCV problem in Egypt. In 2014, we had the highest prevalence in the world, and we had as many patients as in 38 countries in Europe, excluding Russia. In 2010, we had the highest age standardized cirrhosis mortality, and almost 1/5 of all deaths in males 45 to 54 years old were due to liver cirrhosis. Regarding the diagnosis rate and treatment rate, we had the lowest diagnosis rate and the lowest treatment rate, and the bubble represents the number of patients. So we had the high number of patients, but this is no more the case. In 2008, we did a demographic health survey, and we discovered 9.7% of seroprevalence and of RNA prevalence, and in 2015, this prevalence was reduced to 7%. These are the phases of HCV management in Egypt. We started in January 2007 with pegylated interferon. We treated almost 300,000 patients with an SVR of 40%. In October 2014, we started using brand DAAs at 1% of its price in USA. Then in January 2016, we started using generic DAAs after comparing them to brand DAAs and ensuring that their efficacy and safety were as the brand DAAs. In this era, we treated almost 2.5 million patients who were aware of their infection with an SVR of 96%. In mid-2018, less people who were aware of their diagnosis registered for therapy. And in October 2018, we started the nationwide screening program with a target of all citizens above the age of 18, which accounts for 62 million citizens. The famous so-called 100 Million Healthy Lives Initiative. The initiative was enrolled in 3 phases. Each phase included 7 to 11 governorates with 5 to 7,000 fixed sites and 17 to 23 million to be targeted in each phase. Most of the screening was done in the primary healthcare units. The screening presented us the heat map of HCV and NCDs, as the screening was not only for hepatitis C, but also for non-communicable diseases, namely diabetes, hypertension, and obesity. And for the first time, we have the HCV prevalence in Egypt to the district level, not only the governorate level, and which was published in New England Journal of Medicine. The fast deployment of screening in 7 months was a huge test for the healthcare system. The infrastructure, we had PCR hubs of 77 devices with a capacity of doing 27,000 samples per day, distributed all over Egypt. We have the kit supply chain, the samples transportation chain, the maintenance system for these devices, the lab information system to have the result of the PCR in the treatment center once the result is generated. We went to Africa with PCR devices that were used thereafter in the COVID PCR. We had in-house programs for the screening initiative and also for the COVID-19. The data entry in these programs, the data entry clerks were trained and they were ready for COVID-19. We had the immediate linkage to care once the patient was screened, once the citizen is screened and turned positive for antibody of HCV, was immediately linked to care with an appointment in the treatment center. We have updated our data registry, which was implicated positively in the COVID era. And this was used also in the COVID-19 vaccines, the same systems. And as you can see, this is a very simple system for hepatitis C and the NCD screening. And we used also telemedicine in the treatment of patients with chronic HCV in remote areas, and which was published in Liver International, which was used effectively in the COVID-19 era. The elimination necessitates to prove not only screening, diagnosis, or treatment, but a sustainable healthcare system that starts from prevention and ends by reduction of viral hepatitis-related mortality. Therefore, we applied the 360 degrees uplift of all elimination pillars in the Egyptian healthcare system. Maybe the COVID-19 slowed down the program efforts. Most hospitals were shifted to COVID-19 response in the beginning. Patients were afraid to go to treatment centers. Screening needed to document reduction of incidence, which was postponed. However, we have a lower caseload and mortality than North African peers and shorter lockdowns. As a result, economy experienced growth during the first year of the pandemic at the time of the global economy shrinkage. So in conclusion, mass screening for HCV and NCDs was a huge test for the healthcare system in Egypt, which came just in time, just before the COVID-19 pandemic. Multiple lessons were learned and applied to COVID-19 response. COVID-19 relatively slowed down the elimination program and relatively delayed the certificate. However, all these lessons helped reduce the COVID-19 burden in Egypt, and we are looking forward to be the first country to be WHO certified for hepatitis C elimination after being the highest in prevalence. Thank you very much.
Thank you, Will. Excellent and concise overview. You covered a lot in a very short period of a remarkable program in its own right as the hepatitis C elimination program, but then showing how it was used to the advantage of the response to COVID-19. Thank you so much for that overview. Let's turn now to Ambassador Jimmy Coker, who has held positions in diplomatic service to the United States government in many ways. He was the U.S. ambassador to Uganda and Burkina Faso. He served as deputy chief of mission at the U.S. embassies in Denmark and Botswana, as well as other diplomatic posts in the UK, Sweden, Zimbabwe, and Mozambique. He was the deputy global AIDS coordinator in the Office of U.S. Global AIDS Coordinators, helping to implement the PEPFAR program for HIV, and also served as the assistant secretary for Global Affairs at the U.S. Department of Health and Human Services for a number of years. So most relevant to our topic today, he has recently been serving as the senior advisor to the Bureau of Global Health Security and Diplomacy at the U.S. Department of State. And just want to thank Jimmy for his contributions to the white paper and look forward to his perspectives today. Jimmy?
Well, thanks very much, John. And first, tribute to you. I think it was about 12 or 15 years ago that you put hepatitis on my agenda, and the coalition that you've built and the team that you've assembled and the success stories that we've heard today are really impressive. And it's a tribute to the team that really has transformed the hepatitis response into something that where elimination is on everyone's agenda. And that's a marvelous result for global health and for the people who are benefiting from your programs. And I am speaking from, after hearing from so many public health experts and clinicians, I'm speaking from the point of view of a policymaker. And so I'll be repeating some themes, but from that different perspective, because when we hear terms like health system strengthening, and that the UN General Assembly, we're going to have special sessions on universal health coverage, on pandemic prevention, preparedness, and response. And maybe the hepatitis community, you don't immediately recognize yourself in those very broad concepts, and people won't be using the word hepatitis and when they talk about those terms. But that's us, that's you. And I think what we've learned today is from these case examples that a strong health system is the best hepatitis elimination platform, but it's also a strong health system is the best outbreak preparedness. And so we're talking about the same thing with the same components and the same people running them. And so as policymakers look toward what needs to be done toward universal health coverage, toward pandemic preparedness and response, the hepatitis program, as we've seen from vivid examples here, is exactly what we need to be investing in and looking toward as good examples. The strong hepatitis programs in several countries were examples of how disease-specific programs are building strong health systems. So sometimes we're told that, well, disease-specific programs are detracting from health system strengthening. And I think we have very good, concrete, empirical evidence that that's not the case, that this disease-specific programs are what we need in order to strengthen health systems and to make them resonant for people who are suffering from very specific conditions that will benefit from a stronger health system and from applying these concepts of health system strengthening to the very diseases that they're designed to combat. And so what are some of the factors that make hepatitis elimination programs especially well aligned with pandemic prevention, preparedness, detection, and response? First, I think one of the conclusions that has been clear from what we've said, but no one has enunciated exactly, is that these are national and regional programs. And national and regional leadership, we learned in COVID, is absolutely essential to execution of such programs. Sadly, COVID taught us that while the global attention and global leadership to a global problem like COVID is valuable, it didn't work. There was no one in charge, and that the global programs did provide some resources, did provide some guidance, some technical assistance, good certification of diagnostics, and so on. It was at the regional and national level that these programs had to be designed and implemented. And that's true for hepatitis programs, and it's also true for pandemic response. We are working on institutions. The negotiations in Geneva are designed to help us do better at a global level, but the national programs are still the key to getting things done and to reaching the people who need help. And I think the hepatitis examples are very important in that strong national programs with enlightened leadership and resources. Yes, it would be great if there were global funds that could reinforce these, and on a case-by-case basis, there's been global support. But you can't wait and depend on WHO or US CDC or the Global Fund or someone else. Don't wait on the program for those funds to come as a prerequisite. You have to start with what you have and build from there and hope that there then can be subsidies when you've proven what you can accomplish with the resources that you have. Then most influenza and now many coronaviruses are like hepatitis vaccine preventable. That's important. Nationwide vaccine programs make sense, but even if nationwide programs are not realistic, there are segments of the population that are most at risk for severe outcomes, both for hepatitis and for many of the outbreaks with pandemic potential. So targeted vaccination programs among at-risk populations can be prioritized, and we've seen good examples of that from our case studies that were just presented. Case detection based on rapid and accurate diagnosis is essential. We've seen very good examples of that in these wonderful charts and cascades that have really been impressive in these presentations. These case detection programs are in turn dependent on developed lab capacity and agile surveillance systems. Again, there's some very good case studies here on those, but we can't take them for granted. As we've seen also, these labs are being mothballed and the PCR capacity is not guaranteed. So we have to realize that these are not just for outbreaks or for COVID. This is a capacity which had a very good example of how this is being preserved for hepatitis because there is an active program with good leadership and sufficient funding. Then case management is important for both COVID and hepatitis, as well as HIV. Test and treat makes sense. This is a mentality that we need to bring to our public health response. But this requires patient follow-up and it requires adherence. So you need a public health system that really is patient-centered, and you need an ability, whether through telemedicine, whether through house-to-house visits, and we've seen good examples of both of those in some of our country studies. But looking at surveillance and case management is a lesson that the hepatitis program has depended on, but which also is valuable for pandemic response. And finally, bringing an outbreak under control requires trusted communicators, accurate information, and refuting misinformation. The hepatitis community knows very well the stigma that's involved in hepatitis, the suppression of information about hepatitis and its causes and its effect, and how that has inhibited scale-up of programs. These are lessons that we've also experienced during COVID, and the problems that has caused at global, national, and local levels in terms of vaccine uptake, in terms of treatment uptake, and of people not talking about the conditions or the preventive measures that need to be addressed is something, again, the hepatitis community with these successful programs has a great lesson to teach all of us in terms of who are the trusted communicators, how can communities mobilize to get those messages across, and how do we deal with misinformation, what are the causes of that misinformation, and what are the accurate data and demonstrations that help people overcome prejudices or stigma they might have, both for themselves and for family members and other members in their community. The hepatitis community has a lot of lessons to offer in these successful efforts. So see, this is not just a biomedical problem. Hepatitis is a political problem, it's an economic problem, it's a sociological problem, it's an ethical problem. And there are a number of communities that need to combine in a successful hepatitis campaign. And again, countries like Egypt and Georgia, which now have national success stories to tell, have been able to mobilize multi-sectoral responses. And this, again, is something we needed in the COVID response. Some of those countries, again, with that base, were able to do better than others when they had trusted communicators, when they had political and ethical leadership who were leading the responses. This is not just a program that is only a biomedical response, because that will lead to some of the sense that if the community is not brought along, if the political leadership's not brought along, if private sector and other economic actors don't realize that they have a stake in the success of these programs, we're not going to be able to achieve elimination, and we're not going to be able to move quickly to maximize our results. So from a policymaker's point of view, the lessons here are extremely valuable. We need to be sure to package them so that we're not just talking to ourselves as a hepatitis community, but to a much larger health systems, universal health coverage, pandemic preparedness community, but also a much larger, but the new office I'm part of at State Department is health is important in bilateral relations between the US and its partner countries. Health preparedness and health security are national security issues. And unless we start thinking in those terms and get this out of the only way we can pay for health is through overseas development assistance, then we won't be dealing with health, the threat that COVID posed, and we won't be dealing with it in a way that all the institutions that need to be involved in the response are involved. If this is only a USAID, CDC issue, we're not going to get the government players on the US side that need to be involved, and we're not going to get their counterparts in foreign ministries and finance ministries and in the private and civil society organizations that need to be mobilized for a hepatitis response, but also for a much wider health system response to play their parts. So I'm really glad. I think this report is a very valuable piece of evidence. Let's be sure we're using it with all the audiences that need to know about why hepatitis, pandemic preparedness, health system strengthening are all the same. This is the same fight. Thanks very much for the good work everyone's doing.
Thank you so much, Jimmy, for those very insightful comments. I greatly appreciate them, as I'm sure everyone else does on the webinar. And just to sort of kick off a little open discussion while we have for the remainder of the time, how do we, I hear you loud and clear, like you strengthen the health system overall, sort of in this context of universal health coverage, and therefore have a system to respond to endemic and epidemic threats. Yet it seems like, for the external investments tend to be directed towards specific diseases, whether it's malaria, TB, HIV, whatever. So how do we, and you're speaking of this at a policy level or, international donor level, how do we make that transition? Or do we just have to rely on better decision-making of national investments? But how can we change the concept of how external donors work to moving it from specific diseases to more of a general health strengthening that can accomplish those specific disease objectives while also recognizing those additional benefits? Any thoughts on that?
Yeah, both the PEPFAR program, where I got kind of my start in global health, and then I moved to UNICEF, which was worried about HIV among adolescents and young people. Both of them looked at hepatitis because we listened to our customers. The people who were HIV positive or at risk for HIV were exactly the same young people who were injecting drug users or were engaging in the kinds of risk behavior that were also put them at risk for hepatitis. And I think that as we look at people who are at risk for other diseases, hepatitis needs to be on our agenda, and that the sense of let's make this patient-centered and system-centered. And if we're doing good surveillance, we're finding those hotspots where we're not just looking for one disease, we're looking for people who are at risk for a number of diseases because of pre-existing conditions, because of at-risk behaviors. And certainly liver disease has a number of causes, but if you're ignoring hepatitis, you're not doing your job. So it does seem to me that those patient-centered approaches are one way to start. And certainly to people who are looking at HIV programs, and PEPFAR has been able in high-risk countries where there's a high HIV burden, looking at hepatitis and being able to support some of the programs that are looking at co-infections. So it is being done, but it of course isn't being done at scale, and it's not being done where hepatitis is the main driver of co-infection. And that is a problem because this is an AIDS program, and we need the hepatitis-driven epidemics in countries like Egypt and Georgia, which are not hotspots for HIV, to show the way of how this actually has implications for wider disease control. And I think they're doing that in those two countries, but there are other places where that need to follow that example.
Thank you. I'm going to turn it over to Mohammed. you did mention, the focus on breaking down silos and having more of an integrated, testing capacity, which can help with emergency response, as well as expanding capacity for hepatitis testing by an HIV program, for example. And you brought that up, early on in the pandemic response, and just want to get your perspectives on, are things changing indeed in Africa, or do we still have a ways to go of breaking down those silos?
Well, thank you, John. It's something that is going to take time because of the various stakeholders involved. We need to first talk to the different partners, funders, and we in the past 1.5 years, I think that's what we've been discussing with the different funders. I had the ambassador talking about PAFA, Global Fund. All of these we need to come together to agree that we need to be more efficient when it comes to resource management and equipment management on the African continent. Also, our member states needs to put in mechanisms that will ensure that these silos are broken. We've seen very good examples in Ethiopia where an integrative approach has been used for community health systems and other aspects. And we feel if the member states can increase their domestic financing and anchor that to what the donors are bringing, that will help in ensuring even some of the excess capacity we have in the different districts can now be changed to the areas of needs, for instance. So it's a work in progress. It's going to take time. It's going to take a lot of advocacy and a lot of showing investment case on how all of this can be put together to increase both efficiency and outcomes and impact overall for the health systems and health outcomes on the continent. Thank you. Back to you, John.
Thank you so much. You focused rightly on this use of the hepatitis testing capacity for COVID-19. And you began to mention you're shifting over to some hepatitis B testing, but obviously because of your success, your hepatitis C testing in volume is declining, and you have less COVID-19 testing now. So what is the is that infrastructure for testing being maintained, or are you seeing some threats to it, as is being the case in other countries of that being put offline?
Thank you for this question. I think we've benefited a lot from the presence of the PCR hubs and machines, but we are still using them for hepatitis C, hepatitis B, less for COVID nowadays. But we are not planning to lose this panel of devices. I think we can build on this for other diseases if needed.
Thank you. And Tamar, has telehealth approaches gained in routine use in Georgia with the use of mobile phones or other even home testing? What's some of the distance-based approaches that are being used now in Georgia as a result, perhaps, of the COVID response?
Well, during COVID response, we've used online clinics run by primary care providers, and it worked really well. We've also introduced telemedicine for antenatal clinics. However, for all the services, we know that it's not possible to have telemedicine and people still need face-to-face interaction. We are now working very actively to have some primary care sites equipped with adequate telemedicine equipment, which would help them to reach out specialists. So it will be family physician to specialist-led consultations via telemedicine service, and patient would avoid unnecessary travel, all that. We have not used the telemedicine mechanism for Hepatitis Elimination program. However, we use it for COVID-19 as well as we've been using it for tuberculosis, VOT, video observed treatment support, and It really helped a lot and improved patients' experience, as well as helped us to improve clinical outcomes. So it's very important to have these technologies in place, and then patients and physicians, they are both happy to have and to try these new solutions. And I hope that we will have a better model soon to share with other partners.
Thank you very much. Examples of moving to patient-centered care. Here we have one last question here. I'm going to turn it over to Jimmy to respond to it. Ambassador Coker, globally, why hepatitis is not combined with HIV, TB, malaria, and neglected tropical disease testing? Take that.
Right.
One?
I saw that question when I responded earlier.
Okay.
I think, of course, it should be. And as I say, both the PEPFAR program and the UNICEF AIDS effort when I was there did look at it holistically, but it does seem to me, and Africa CDC and the office where I am now is headed by John Nkengasong, who did this very well, and as a laboratorian, he is really looking at how the lab part of that should be multisectoral. That to have a specific disease-centered lab makes no sense at all. From the lab point of view, we need to be sure that they're doing multiple tests, but at the same, the surveillance systems and being sure that we're testing for comorbidities as we're having these disease-sponsored programs. It actually costs very little once you have that patient population, which is the target for a disease-centered program, to be sure that we're testing for comorbidities, and at the very least having relationships with referral systems and treatment for these comorbidities is in everyone's interest, and to have that patient-centered so that we're sure that as the patient is identifying related conditions, that those are handled by the program that has the funding, but that the funding doesn't stop with the one disease that perhaps for which the funding was related. The Global Fund is moving in that direction. It's important also that as all of you are part of country coordinating mechanisms and as Global Fund applications, that you're sure that there's a paragraph there or a funding stream for hepatitis identification among those people in the TB and HIV programs, because this is the Global Fund would welcome that kind of additionality, but they're not going to prescribe it. They're not going to add it onto the program. But if the country requests it, and if it's a civil society group or the Ministry of Health or a hepatitis program within the country, they would welcome that kind of addition, because comorbidities are really important. And Global Fund, of course, reaches a number of countries where AIDS and malaria aren't the main causes of morbidity and mortality. So the question's well taken.
Thank you very much. And Global Fund, as you just touched on, recently expanded their criteria to permit countries to request funding for hepatitis testing of pregnant women and key populations for both hepatitis B and hepatitis C. So it does open that, but to your point, countries have to ask for that support. Global Fund, it's not their business to do that outreach, and so that's where organizations like the Coalition come into play, is to build that awareness in that advocacy. So I want to thank everyone for an excellent webinar today. We covered a lot of different aspects of this relationship between hepatitis elimination and pandemic preparedness. I want to thank my colleague in Egypt, my colleague in Georgia, my colleague in South Korea, my colleague at Africa CDC. I want to thank Ambassador Coker.
And Pakistan.
And then lastly, our hepatitis elimination fellow, but not least, Dr. Nita Ali in Pakistan. So I want to thank you all for an excellent discussion, and just remind, pardon me, everyone, that this is video will be available on our website as well as the slide presentations. Please keep in touch. I'm at jward@taskforce.org, and look forward to working with all of you to eliminate hepatitis around the world.
We can do that. John, just to tribute to you and to this coalition, we can do this. I mean, here's a public health goal that actually is achievable and measurable, and we don't need new science. We now, luckily, have a cure for hepatitis C, and that was not the case 10 years ago. So let's go for it.
Yeah.
We know what to do.
Absolutely.
Yeah.
We will use that soundbite in multiple ways from now on, Jimmy. Thank you so much for
Thanks.
All right, great inspiration here to end this webinar. Look forward to working with all of you. Thanks so much again. Take care. Bye-bye. We'll be in touch.
Bye.
Bye.
Thanks. Bye-bye.